and sovereignty was never ceded. So, and I'll just quickly do an introduction to the Waiting Room Project and who we are and what we do. So we're just a contemporary art space located within the waiting room at Sydney Sexual Health Centre in Sydney Hospital, right in the CBD. And we mainly exist as a way of kind of alleviating anxieties and stress in a clinical waiting room, as people are quite nervous or quite anxious to go in for the sexual health checkups and receive the results. So I think it's quite an interesting non-white cube space, and how we really love experimenting with artists to see how they activate the space in different ways. So there we go. But yeah, so that's who we are. I am Joey. I'm one of the co-curators, and this is Natalie in the top corner. He was our other co-curator. We're both artists and emerging curators at the moment. But yeah.
Yeah. So hi, I'm Natalie. My pronouns are she and her.
Sorry, my pronouns are she, her too.
And so welcome to this panel. We're so lucky to have Joselo as our first exhibiting artist of the year. His practice revolves around the intersection of art and medicine, and this panel in particular will delve into logistics and many intimate details about sexual health in general. Just a few things. So everyone, can you please keep your mics off while the speakers are speaking? And if you do have a question, there's a hands up button at the bottom left corner. So if you press it, you can like unmute and you can ask anything. Also, this whole session is recorded, so feel free to not show your camera if you don't feel comfortable. And without further ado, I'll let Joselo introduce himself and his speakers.
Hi, my name is Joselo Ortiz. I'm a medical doctor from Mexico. I arrived to Australia 3 years ago to do a master in sexual and reproductive health with clinical specialty in HIV and STIs. I've been working with the human papillomavirus since like 5 years ago. It all started in the public health. The public hospital of Mexico. Called Hospital Universitario. And since then, I haven't stopped. I think through this agent, particularly the human papillomavirus, we can understand our societies better and, kind of see our behaviors and patterns through it. And I don't know, Samantha or Justin, do you want to introduce yourself?
Yeah, my name's Samantha Blake. I'm a clinical nurse specialist in sexual health. I've worked at Sydney Sexual Health Centre for a number of years, and now I'm at the New South Wales Sexual Health Info Link, which is a statewide sexual health information service, and we do sort of a mix of information and referral for the general public and health professionals, and various sort of health promotion and results provision referral services.
Justine?
Hi, my name's Justine Worrell. I'm a clinical nurse specialist as well, but not in this field. Mine's in intensive care. So my participation in this panel is more along the lines of myself as a client patient accessing testing for HPV and my experiences in that area.
Should we start with our first topic? We've got a question for Sam. So what is HPV and who gets it?
Well, HPV is the human papillomavirus. And genital HPV is one of the most common STIs worldwide. It's a virus that's transmitted on the surface of the skin, and so it's really, really difficult to avoid. Even condoms, which work really excellently for infections like HIV that are transmitted through body fluids, they do decrease the risk of transmission when you've got penetrative sex, but they're not 100% because the virus is on the surface of the skin, and parts of the body that are rubbing against each other during sex can, include other areas that are infected. So essentially, pretty much all of us will be exposed to HPV. There are dozens of different strains of HPV. And in some ways, it's considered the common cold of STIs, because for most of us, we will get infected and it comes and goes without much consequence. But there are a number of different strains of HPV that some people's bodies will have difficulty clearing, and over many years, usually, they can become cancers. So, through over time, we've discovered particularly a close link between two types of HPV, HPV 16 and 18, and cervical cancer. And out of that, we've developed a number of different screening programs and interventions that kind of address that. But those are only two types of many. And for a lot of people who even get those high risk types, it will be cleared naturally by your own immune system. But we don't have a cure for it. So there's a need to look at it closely when we find those types, and watch them and do some interventions if they are persisting.
Well, that's really interesting. So I was wondering, can any of you tell us about the general history about HPV as a virus?
Well, yeah. Thank you, Samantha, for that amazing explanation. So our history is both personal and collective with HPV. So on a personal level, HPV kind of becomes part of the history of a person through the impact of the disease, the emotional stress that a lesion can cause. But at a species level, it is also part of our history. There's this doctor called Harald Surhausen. He won the Nobel Prize in 2008 for his discoveries about HPV causing cervical cancer. And in his investigations, he discovered that it has been with us for millions of years. Unlike HIV, which just recently was introduced into our species in the last few decades, there's also some cases in the literature about people in the 1600s. Particularly, there's a noble woman from Italy called Maria de Aragon, and she was like a typical example of a Renaissance noblewoman. They did some molecular studies to the genital area of the mummy, and it revealed the presence of HPV serotype 18. It follows us to everywhere we go. It's basically in every country in the world, and to different extents.
I'm muted. All right. So our next question is, has the testing process for HPV in Australia always been the same, or has it changed over the years?
This is to anyone.
Sorry, I can answer that. Australia started the Pap smear program in 1991, which has been an incredibly successful health intervention, and it reduced cervical cancer by 50%. And the vast majority of cervical cancers that still persisted were people who were not participating in the program, so either had never had Pap smears or had Pap smears quite infrequently. So the screening program has been quite successful. That said, in about 2007, the Hpv vaccination was introduced. And in Australia, that started with vaccinating girls at 12 to 13. So trying to catch people before they're sexually active, because as I said, these HPV viruses are really ubiquitous. It's pretty much as soon as you're sexually active, you become infected with HPV. So trying to get them before that. And then a few years later, in 2013, that program was extended to boys, realizing that There are some men who are getting HPV who are not having sex with women, who are having sex with each other, and HPV is also associated with other kinds of cancers, so penile cancers and anal cancers as well. So Australia now has quite a comprehensive vaccination program, and we're already seeing pretty big shifts in genital warts, and we expect to see shifts in cancer over time as well. But in 2017, there was, as we're learning more about HPV, the screening program was shifted from the Pap smear program, which is primarily looking at cell changes on the cervix, to what we're calling just cervical screening testing, which is really HPV testing as the first point. Because we learned so much that HPV type 16 and 18 are much more specifically associated with cervical cancers than those cell changes, which can be quite transient. And also sometimes the cell changes themselves don't show up as specifically as a HPV diagnosis. So the whole program changed a few years ago, which has been interesting for me as a nurse answering questions to people, because what's happened is, and I think that there's maybe been a little bit of a failure in health education in explaining the change, but everyone's now discovering that they're infected with HPV, which has been really distressing because people understand it's a sexually transmitted infection. And while they may have always had it and had it through all the previous Pap smears, the Pap smears weren't necessarily diagnosing them with an STI. So there's a lot of questions and concerns about what it means to be diagnosed with HPV, even if you've got a low risk type, or if it's a high risk type, does that mean you have to stop having sex with anyone? All those kinds of things are coming up. But the good news with it is that it does seem to be a more accurate screening system, and is likely to identify and prevent more cancers.
Thank you for your thorough explanation. We now have a question that is asking specifically about the process. So how do you feel about the process of HPV testing in general, and what are your thoughts?
Yeah, so I sort of worked out that I'd had 25 Pap smears over my lifetime, and you never become used to them. They are as unpleasant the first time as the 30th time. As you're saying, Samantha, they're confronting, and that also depends on the practitioner that is providing that service as to how they choose to engage with you. Are they actually skilled at taking a Pap smear? Because that in itself requires someone to have a reasonable understanding of the anatomy of the female cervical canal, the vaginal canal. So if they choose to insert the speculum straight, you get a really strong pain and a strong pinching sensation. Whereas if they tend to invert it and put it in a slope, it's more comfortable. That's just the mechanics of it, which can really be very, very unpleasant. The emotional part of it certainly is. I've had no adverse psychological sexual issues in my life, so I come with a clean slate. But certainly with people who have experienced any form of sexual violence or just sexual dominance, being in a position where your hands, you've got to keep them away, and your legs are up in stirrups, and you just have to basically comply. That test in itself can be a very, very distressing process. A necessary test, but nevertheless distressing. So it is then up to the social competence and sensibility of the practitioner, be it nurse, doctor, to assume that every patient comes with a psychology which makes them very anxious about this test. So just assume that whoever is presenting will be confronted, and therefore, if you deliver that appropriate care, then you're going to increase the likelihood that that client patient will come back again for a repeat process. Also, additionally to that is I come from a very, very privileged position of being white, female in a reasonably well-off demographic, so I can access this test whenever I want. We also see a lot of women who come from ethnic backgrounds where there is the understanding of that transmission of HPV, particularly amongst their husbands, is that if their wife has HPV, then she must have slept around.
You know, speaking on that point, it's very interesting that biological record has such a strong social impact, right? Like, we're more afraid of the social impact than the development of a disease. And that has to do with our preconceptions about sexuality as well. And I just wanted to ask you, so now in Australia, you can do the cervical test, right? Which can be, you can test it yourself. Like, for the people who are not in Australia, like they give you like a swab, if I recall correctly. They give you like a swab, and then people could introduce it by themselves and do like get a sample from that, and then put it in a tube, and then give it to the doctor or nurse for it to be tested. How does that changes, for example, as in being now in charge of your own samples, right? Instead of somebody else being in charge of it. Like, do you think that also empowers the person, the patient, to be in control of the situation more than before? And is that kind of parallel to all these advances in the sense of empowering women to take, like to give them more, like, or to more to like oppress them less in a sense, like to be more empowered about their decisions? Do you think that has to do, that has like an impact in that?
Without a doubt. So for a number of reasons, as I said, it's a really unusual position to be in, to take a cervical sample. Like being flat on your back, legs up, bent. It just seems, and when you have to put a speculum in, it seems, as I said before, if someone's not really understanding the anatomy properly, it can be a really unpleasant experience. So to the point of doing your own sample, I know that it's been discussed with lots of younger girls, in their 20s, that you take the sample the same way you might insert a tampon. So that first time when you're sort of getting used to it, you put one leg up on the toilet seat lid and you sort of, you get the right angle. It's a very simple thing to do.
On that note, we're talking about how the self-samples, it's like a practical way for women to feel, to lift that barrier of testing. But what about, like, from the perspective of men and other people in society, how do you think they can accommodate, or what are some shifts that we need to change in order for this test to be even smoother and less traumatizing almost?
And there actually isn't a screening test for men for HPV, so it can be quite challenging to kind of, when I speak to women on the phone who've been diagnosed with HPV, they're very distressed about giving it to their partners, or their partners call and say, I've just found out that my wife or my partner has HPV. What do I do? Am I going to get cancer? Or, this kind of thing. But there actually, there aren't screening tests for men, but men are mostly the vectors for HPV for women. So it just seems to be, there are very strong links between HPV and other kinds of cancers that men can get, but the prevalence of those cancers, I believe, is lower. Maybe Joselo can speak to that as well.
For that, Sam, before we move on, we have a raised hand if you would like to turn your mic off. And
Thank you so much. I've just got a question about the cancers that can come from HPV infections. How aggressive are they? Does it depend on which part of the body they originate in? And also, is the major challenge the pathology and the treatment of these cancers, or is it getting people in for early testing so that it can be treated when they're small and haven't metastasized or something like that?
It depends also on the stage it is diagnosed in. So, for example, the cervical test is a very advanced test at the moment because it just it screens for the antigens of the virus, for the presence of the virus, whereas a pap smear is searching for the changes that come from an infection. So you might have the virus, but yet not have much changes on your skin. Mm-hmm. And that's why the time span of the cervical test is 5 years versus the pap smear that will be 2 years. Because that, in that sense, it can be detected before. So to answer your question, I think it will depend on the stage that it is diagnosed in. That's why it's important to get the screenings. I think for other parts of the body, there's also screenings. So, for example, Australia has this research called SPANC, and it's about the screening of the anal area as well. But that has not yet been introduced into, like, in general in the public health systems. It's something more for priority populations. But I think people can request to or like inquire about how to get in touch with this research in Australia. I think in the future we will start to look at the presence of HPV in different parts of the body. I have some medical peers in Mexico. They are nose and ear surgeons, and they are seeing a very steady escalation of the oropharyngeal cancers by HPV. So I think this will eventually be introduced like the same process or method of the cervical test into other areas of the body, and that's how you can detect it soon. And if it's detected soon, then it can be treated easily. There are very different treatments depending on if it is infecting the the mucosa of the skin, or which region of the skin is. You for example, you have like cryotherapy, or you can have ablation therapy, or even depending if it's on the outside, you can have like some creams. But anyways, it will depend on the stage.
Mm-hmm. And a follow-up question to that then is, obviously these are such intimate areas. So how effective are these at removing either warts or cancerous lesions or precancerous lesions, and not disfiguring the patient as well?
For women who have to just have an ablation or diathermy done because they are CIN1, perhaps, that in itself is a very simple procedure done in rooms under a local anaesthetic. It's, when we ask people to rate that pain factor, the discomfort factor, not the embarrassment factor, but the pain factor, they say it's about a 3 out of 10. So it's not considered to be a painful procedure. The downside afterwards is very minimal as well. It just requires 2 weeks of no immersing in water and a 3-week abstinence from sex, which a lot of women in their 40s and 50s are very grateful for. So that's the one bonus for them. But that diagnosis and treatment is very, very simple in that CIN1 stage, that early cancerous stage. However, the misinformation that's out there is because people then extrapolate that information of HPV being a slow-growing virus, a slow mutating virus, that they think that it's taken 10 years to get to the point where it's been detected, that they've got another 10 or 20 years before it develops into something else. but obviously we know that to be incorrect, that once you are CIN1, you can very, very quickly become CIN2, then 3, and you have a very aggressive, invasive cancer that cannot be treated. You're given chemotherapies just to retard it for a period of time, but it's already gone. So I think the information that probably needs to be added to the body that's already out there is, it is slow growing, but once it hits that mutating phase, it's a rapidly growing invasive cancer, and therefore it shouldn't be seen as being sedentary for too long.
I guess my lead-up question, a follow-up question is, how do you think like feminism in Australia has changed the way sexual health is regulated or educated in our society in Australia? This is to any of you.
So given I'm significantly the eldest person on this panel, with regards to the feminist movement, it certainly has been to the detriment of male health. And not that we should have ever pulled back from the strong advances and focus on female health, certainly not at all. But it should not have taken centre stage at the expense of men. So I don't think it was I don't believe it was an intentional oversight of men's health. It's just that the feminist movement was and still is robust and unapologetic. So there is. I think we now need to lend our voice to male issues, because as a mother of male and female children, I obviously would advocate for equal health services for both. So, I'm confronted that I didn't challenge that health dynamic earlier with regards to the vaccine for men. When my daughter was given it when she was 12 or 13, the question for me is, why did I not advocate that for my son when he also reached that age? So there's the conflict. Samantha, I'm really interested in your perspective, because you have always been on that coalface of sexual health. You're certainly going to be have a stronger understanding of feminism and the feminist movement impacting health portfolios and profiles in general.
Well, yeah, I mean, I don't know. I think that's hard to answer. One, because I'm an immigrant to Australia, right? So I don't have sort of that visceral sense of change over time in this country, and maybe also don't have kind of the historical local knowledge to speak to it so directly. But I'm not sure that it's necessarily like the feminist movement that has made the majority of interventions around HPV on the female body or bodies with a cervix. I mean, in some ways you could think, like birth control, that's something that has always been the burden of women to manage, whereas, pregnancy is not possible without sperm. And so you could have chosen to have all kinds of medical interventions on male bodies or bodies with sperm. And likewise, cervical cancer mostly comes from men who have HPV. And it's women who have the burden of having to lie on their backs and have these really invasive kind of procedures where we could target all the HPV prevention towards men. And if we eradicated it from their bodies, then it wouldn't be such an issue for women. So, I'm not sure if it's such a direct line that way. I mean, I think more the issues of gender inequality end up being about health access to information, access to services, the ability to get to doctor's appointments when you've got childcare responsibilities. So I think I would place it a bit differently. And I also think it becomes, quite challenging. I think as Joselo talked about as well for the way that we teach women to feel about their sexuality and, about being pure or being good in a sexual way. To be diagnosed with an STI has, quite a heavier burden on women often than it does on men who, the framing that we have about STIs for men can be not always great, but mixed up with, virility and other kind of positive associations, where for women, it can be really quite devastating and alienating. So, I think I would probably place it differently, but I think, Joselo's framed this discussion in such an interesting way, because HPV is so ubiquitous. It becomes a really interesting site for the way that people interact with an infection and with its association with sex and with access to services, which we recommend in Australia that every single person from 25 to 70, regardless of sexual history, is getting these tests for the whole span of their lives. Anyone with a cervix, I should say. It's quite a comprehensive lens, I guess, to look at, how it impacts women and how we frame it. And also, not women as well. So non-binary people, trans men as well, have a whole complex relationship as well with their cervix. And, for a long time, lesbian women or women who had sex with women, there was a lot of poor information that they did not need to have cervical screening. And I feel like slowly it's developing, more consistent messaging in healthcare, but a lot of GPs had very terrible information about the sexual health of women who have sex with women or people who don't have sex with cis men. And so, just the lack of information for certain populations is also, has a huge impact on their ability to access appropriate services.